Welcome, curious minds, to the deep dive. Today, we're plunging into the microbial world to unravel the captivating story of, well, a truly paradoxical organism. This isn't just a surface-level glance, it's a deep exploration. Custom-tailored for you, our discerning medical microbiologist listeners, cutting straight to the core of what you need to know. We're talking about Bacteroides fragilis, a bacterium that perfectly embodies that phrase, microbial Jekyll and Hyde. It's both a vital, helpful inhabitant of our gut and, surprisingly, a formidable pathogen when it steps out of line. Our mission today is to distill the essential insights about Bacteroides fragilis, its precise place in the bacterial family tree, the telltale signs we look for in the lab, the spectrum of diseases it can cause, and critically, the latest on how we treat it. That includes specific guidelines and the ever-evolving landscape of antimicrobial susceptibility.
Indeed. All the information we'll unpack today has been meticulously gathered using a Gemini deep search. And for those who appreciate visual context, the images referenced were created with Microbe Canvas. As always, for a full list of sources, the detailed guidelines we'll touch on in a more, in-depth look, remember you can access the notebook document that accompanies this deep dive.
All right, let's unpack this fascinating organism, starting with its core identity and that remarkable dual nature. So let's begin with the summary. Bacteroides fragilis truly holds a unique and, well, paradoxical position. What's the most compelling way to explain how it navigates being both a beneficial commensal and a virulent pathogen?
What's truly fascinating here is its incredible adaptability. You see, in its natural home within the human gut, Bacteroides fragilis is a crucial ally. It helps us break down complex plant fibers, producing short-chain fatty acids that nourish our colon cells, and it plays a vital role in sculpting our immune system. But here's where the paradox comes in. If that protective mucosal barrier is breached, say, by surgery, trauma, or disease like diverticulitis, it transforms. It becomes a major opportunistic pathogen, primarily responsible for serious intra-abdominal infections, abscesses, and bacteremia.
That rapid shift from friend to foe is remarkable. So what are the specific tools this bacterium possesses that give it such pathogenic potential?
Two key virulence factors really stand out. First, it has a polysaccharide capsule. Think of this as its sort of stealth cloak. It helps the bacterium evade our immune defenses and, crucially, promotes the formation of those walled-off abscesses. That creates a perfect oxygen-free haven for the bacteria to thrive.
Okay. Capsule for abscesses. And the second factor?
Second, and this is particularly unsettling, certain strains produce the Bacteroides fragilis toxin, or BFT. This toxin has been definitively linked not only to inflammatory diarrhea, but also, quite surprisingly, to promoting colorectal carcinogenesis. It's a true oncomicrobium.
Wow, an oncomicrobium. The idea of a microbe actively contributing to cancer is a powerful revelation. When we're faced with these serious infections, what are the fundamental principles guiding our management?
Well, the cornerstone of managing these infections always comes down to two things. Aggressive source control, which is physically eliminating the source of infection, like draining an abscess.
Right, source control first.
Exactly. And then critically appropriate antimicrobial therapy. The landscape of antimicrobial resistance for this organism is constantly shifting, but the good news is that metronidazole and carbapenems remain highly effective. They're still cornerstones of our therapy, even as resistance to penicillins is universal and clindamycin resistance becomes increasingly widespread.
Okay, good to know those cornerstones still hold for now. Let's zoom out a bit now and look at its formal classification. Where does Bacteroides fragilis fit in the grand scheme of bacteria? And what's the most clinically relevant aspect of its taxonomic position for our listeners?
Right. The key takeaway here is that Bacteroides fragilis isn't just a single species. It's the leader, the type species, of a larger family known as the Bacteroides fragilis group. This group actually includes over 20 related species. Its full classification places it firmly within the Bacteroideota phylum.
Over 20 species in the group.
Yes, and this distinction is crucial for medical microbiologists because while they're related, different members within this group can exhibit surprisingly varied antimicrobial susceptibility patterns. So what might treat one Bacteroides effectively might not work for another. It's worth remembering it was actually first described way back in 1898 as Bacillus fragilis before its reclassification.
That's a really important point about the group versus the individual species susceptibility. Now, let's get into the nitty-gritty of lab identification. When we get a sample, how do we first recognize this elusive bug? Let's start with the gram stain. What should we be looking for?
Okay, on gram stain, Bacteroides fragilis shows up as a gram-negative bacillus. But here's the kicker. And this is a vital microscopic feature. It exhibits marked pleomorphism.
Pleomorphism, so lots of different shapes.
Exactly. You'll literally see cells varying wildly in shape, from tiny cucobacilli to long, slender rods, sometimes curved, often with rounded ends, and even central swellings or prominent vacuoles. It's truly a chameleon under the microscope.
Sounds like it's trying to play hide and seek. Are there any more subtle clues, perhaps, that can give us a hint?
Absolutely. Another characteristic feature is that Bacteroides fragilis tends to stain faintly. This subtle clue can be really helpful in distinguishing it from more robustly staining facultative gram-negative rods, like Escherichia coli, especially when you're dealing with polymicrobial infections, such as those nasty intra-abdominal abscesses.
Faint staining, okay. Good tip.
Oh, and it's always non-modal, so no flagella to worry about.
Right, non-modal. So we've got our gram stain. But how does this elusive bug behave when we try to grow it? It's an obligate anaerobe, right?
Correct. It is an obligate anaerobe.
What tricks does it use to survive, and what peculiar traits do we look for on the plate?
Well, you're spot on. It is an obligate anaerobe. However, and this is one of its clever tricks, it's notably aerotolerant.
Aerotolerant, but it's an anaerobe.
Exactly. It can survive in low oxygen environments because it produces detoxifying enzymes like catalase and superoxide dismutase. Let's hang on a bit. On enriched anaerobic media, like Brucella blood agar, we typically see it form non-hemolytic circular convex colonies that are gray to white, usually around 1 to 3 millimeters in diameter after 24 to 48 hours of incubation.
Okay, gray-white, non-hemolytic. I've heard Bacteroides Bile Esculin agar is a go-to for its isolation. How exactly does that work its magic in the lab?
Bacteroides Bile Esculin agar, or BBE. Yes, it's truly a workhorse for Bacteroides fragilis.
Yeah.
It's both selective and differential.
How so? Selective and differential.
Yeah. It contains 20% bile, which actually stimulates the growth of the Bacteroides fragilis group while inhibiting many other bacteria, and gentamicin to knock out most other anaerobes and facultative anaerobes. That's the selective part.
Got it. Bile and gentamicin.
And for the differential part, Bacteroides fragilis produces an enzyme called esculinase. This enzyme hydrolyzes esculin. When that happens, it reacts with ferric ions in the agar to form a distinctive black precipitate.
The blackening.
Precisely. So, gray colonies around 2-3 millimeters surrounded by a zone of blackening on BBE agar are a very strong presumptive identification for the Bacteroides fragilis group. Just a note, some other members, like Bacteroides vulgaris, might grow, but they won't consistently produce that classic blackening.
That's a great practical tip. Blackening on BBE equals likely Bacteroides fragilis group.
Okay, beyond these visual and growth characteristics, what are its defining biochemical traits?
Definitive identification often uses a panel of biochemical tests, or increasingly, MALDI-TOF-MS, that rapid fingerprinting technique. Right, MALDI-TOF is becoming standard.
It is. Biochemically, Bacteroides fragilis is catalase positive, grows robustly in 20% bile, and of course, hydrolyzes esculin as we just discussed. Indole production can be variable, but it's consistently negative for nitrate reduction and urease.
Okay. And sugars.
When it comes to carbohydrate fermentation, it's positive for glucose, lactose, sucrose, and starch, but notably negative for erbinose and rhamnose.
Got it. What about its intrinsic resistance? That's so crucial for empirical therapy.
Absolutely critical, you're right. Bacteroides fragilis is universally resistant to penicillins, period.
Universal resistance, why is that?
Because it has a potent chromosomally encoded beta-lactamase, essentially. A built-in unshakable defense mechanism that breaks down those antibiotics. It's actually a cephalosporinase.
A cephalosporinase and other intrinsics.
And like all obligate anaerobes, it's also inherently resistant to aminoglycosides because those drugs rely on oxygen to enter the bacterial cell, a process impossible in an anaerobic environment.
Right. Oxygen-dependent uptake doesn't work for anaerobes. Makes sense. So we've dissected its identity in the lab, from its pleomorphic look to its metabolic quirks and built-in defenses. Now let's shift from recognizing our microbial Jekyll to understanding exactly how it transforms into the Hyde we fear in our patients. How does this remarkable shift from symbiont to pathogen actually occur?
It's quite fascinating. Within the colon, the non-enterotoxigenic Bacteroides fragilis is truly a key mutualist. It's diligently breaking down complex plant polysaccharides, producing those beneficial short-chain fatty acids. And the specific molecule it carries, capsule or polysaccharide A, is instrumental in shaping our immune system. It actually induces anti-inflammatory interleukin-10 and promotes the development of regulatory T cells, which help keep our immune responses in check.
So it's actively beneficial in the gut, helping maintain balance. When does it decide to, turn bad?
The turning point, the shift to pathogen, almost always happens when there's a breach in that vital intestinal mucosal barrier.
A breach, like from surgery.
Exactly. Surgery, trauma, or an underlying disease like diverticulitis. Once it escapes into a normally sterile site like the peritoneal cavity or the bloodstream, that's when its virulence factors kick into high gear and immediate disease.
Okay, let's talk more about those virulence factors. You mentioned the polysaccharide capsule earlier. How does that contribute specifically to its disease-causing potential?
The polysaccharide capsule is, without a doubt, its primary virulence factor when it comes to abscess formation. It's both antiphagocytic.
Meaning it avoids being eaten by immune cells.
Correct. It protects the bacterium from being gobbled up by our immune cells, and it directly triggers a robust inflammatory response. This response leads to that classic walled-off abscess, which in turn creates the perfect anoxic environment for Bacteroides fragilis to proliferate, effectively shielding itself from both immune attack and many antibiotics.
Clever in a nasty sort of way, creating its own safe house.
And what about the Bacteroides fragilis toxin, BFT? How does that mechanism work, and what are its clinical implications? Right, the BFT. Produced by specific enterotoxigenic Bacteroides fragilis strains, it's a zinc-dependent metalloprotease. What's crucial here is that it cleaves E-cadherin, a protein vital for maintaining the integrity of our intestinal epithelial barrier.
It breaks down the gut lining junctions.
Precisely. When that barrier is disrupted, you get fluid loss and inflammation. The toxin also sets off a pro-inflammatory signaling cascade. This is incredibly significant because we now have compelling evidence linking chronic colonization with these enterotoxigenic Bacteroides fragilis strains to an increased risk of colorectal cancer.
Wow.
Truly positioning it as a potential oncomicrobium. That's a real game changer in our understanding.
That link to colorectal cancer is truly groundbreaking. Given its pathogenic potential, what's the spectrum of infections we typically see with Bacteroides fragilis?
Well, Bacteroides fragilis is the most common anaerobic pathogen we encounter in intra-abdominal infections. These infections are almost always polymicrobial.
Meaning multiple bugs involved.
Yes, multiple bacteria are involved, and they typically arise from a breach or spillage from the colon. We often see a biphasic model. An initial acute peritonitis, which is usually dominated by facultative aerobes like Escherichia coli.
The initial E. coli phase.
Followed by the crucial stage of abscess formation, which is primarily driven by anaerobes, with Bacteroides fragilis leading the charge. This biphasic nature dictates that our empirical antibiotic coverage absolutely must target both aerobes and anaerobes from the start.
That makes sense. Cover both phases. And it's a big player in bacteremia too, isn't it?
Absolutely. It's the most frequently isolated anaerobe from blood cultures.
Really? The most frequent anaerobe?
Yes. And when we find it in the bloodstream, it nearly always points to an intra-abdominal source. Anaerobic bacteremia is a severe condition, often associated with reported mortality rates as high as 30%.
30% mortality? That's serious.
It is. From a clinical perspective, if you're seeing foul-smelling discharge or gas in tissues or abscesses, Bacteroides fragilis should immediately jump to mind.
Good clinical clues. Beyond intra-abdominal infections and bacteremia, are there any other notable infections where Bacteroides fragilis plays a significant role?
Yes, definitely. Besides the inflammatory diarrhea caused by the enterotoxigenic strains, Bacteroides fragilis is also implicated in a range of other serious infections. We see it in diabetic foot infections, where the anaerobic environment is conducive to its growth, decubitus ulcers, necrotizing fasciitis, a rapidly progressive and life-threatening soft tissue infection.
Neck-vasc, truly dangerous.
Indeed. And also in various pelvic infections, including pelvic inflammatory disease and tubo-ovarian abscesses, particularly those that are post-procedural gynecologic infections.
Okay, quite a wide range of potential damage. So, understanding this formidable pathogen, how do we treat these serious Bacteroides fragilis infections? What are the guiding principles that shape our therapeutic approach?
As we touched on earlier, the cornerstones are always source control and appropriate antimicrobial therapy. Source control is paramount.
Say more about source control.
It means physically eliminating the origin of the infection, things like draining an abscess, debriding necrotic tissue, or repairing a bowel perforation. I cannot stress enough that failure to achieve adequate source control is a primary reason for treatment failure, even with the best antibiotics.
Right. Antibiotics can't sterilize a big collection of pus or dead tissue. Let's delve into specific guidelines for antimicrobial therapy. What's the approach recommended by the Dutch guidelines from SWAB for adults?
Okay, the Dutch Working Party on Antibiotic Policy, SWAB, emphasizes a very targeted, stewardship-conscious approach.
Yeah.
For complicated intra-abdominal infections or sepsis with an abdominal focus, they often recommend combination therapy.
Combination therapy, why is that?
The rationale here is to cover the polymicrobial nature of these infections while preserving broader spectrum agents where possible. Good stewardship.
Makes sense. Can you walk us through some specific regimens, perhaps outlining a typical dose, frequency, and duration for our listeners?
Certainly. For complicated diverticulitis and other intra-abdominal infections, a common first choice is intravenous ceftriaxone 2,000 milligrams once daily, combined with metronidazole 500 milligrams 3 times daily.
Okay, ceftriaxone plus metronidazole.
Right. For secondary peritonitis, cefuroxime 1,500 milligrams 3 times daily, plus metronidazole 500 milligrams 3 times daily, both intravenously, is a key recommendation. Alternatives for complicated diverticulitis can include amoxicillin clavulanic acid 1,200 milligrams 4 times daily intravenously.
And for more severe cases, sepsis.
For sepsis with an abdominal focus, options escalate to piperacillin tazobactam 500 milligrams 4 times daily intravenously, or meropenem 1,000 milligrams 3 times daily intravenously.
Got it. Piptazo or meropenem for the really sick ones. And duration.
Typically, treatment duration is 4 to 7 days and can often be shorter if excellent source control is achieved.
4 to 7 days post-source control. That's shorter than it used to be.
Exactly. Driven by data showing shorter courses are often sufficient with good source control.
That's a very practical overview of the Dutch recommendations. What about international guidelines, specifically the IDSA guidelines? What's their take? And are there any key warnings or updates for our listeners?
Okay, the 2010 Infectious Diseases Society of America guidelines provide a comprehensive, risk-stratified approach. It's important to note that these guidelines are currently undergoing an update, so you'll want to keep an eye out for the newest iteration.
Ah, good point. An update is pending.
Yes. But a strong word of caution from these guidelines, still very relevant today, is against using sulfaten and clindamycin for empirical therapy due to the high and concerning rates of resistance we've discussed.
Right. Clindamycin and sulfaten are generally out for empiric use now.
Pretty much. So what do the IDSA guidelines recommend for different severity levels?
Yeah, what are their preferred agents?
For community-acquired infections, particularly those of mild to moderate severity, single agents like ertapenem, moxifloxacin, tigecycline, or tecarcillin clavulinate are good options. If combination therapy is preferred, metronidazole can be paired with cefazolin, cefuroxime, ceftriaxone, ciprofloxacin, or levofloxacin.
Okay, several options there, and for higher risk.
For high-risk community-acquired infections or those that are healthcare associated, the recommendations shift to broader spectrum single agents, such as imipenem cilastatin, meropenem doripenem, or piperacillin tazobactam.
So similar broad agents as SWAB for severe cases.
Yes, broadly similar. Combination therapy in these severe cases involves metronidazole plus cytopine or ceftazidime. Similar to the SWAB guidelines, the duration of therapy is typically 4 to 7 days once adequate source control is achieved.
Consistency and duration is good. And are there different considerations for pediatric patients when we're dealing with Bacteroides fragilis infections?
Yes, absolutely. While the fundamental principles of source control and broad-spectrum empirical antibiotics remain consistent, drug selection and precise dosing must be carefully tailored for children.
How so? What are the key differences?
Well, a key difference, reflecting the resistance trends, is that clindamycin is no longer recommended for routine empirical use in pediatric patients, just like in adults.
Okay, no clindamycin empirically for kids either. Can you provide some selected pediatric dosing for some of these key antimicrobials, just for reference?
Certainly. For meropenem, a typical dose is 60 milligrams per kilogram per day, given every 8 hours. Piperacillin tazobactam is 200-300 milligrams per kilogram per day, based on the piperacillin component, administered every 6 to 8 hours. Ertapenem, for children aged 3 months to 12 years, is 15 milligrams per kilogram, with a maximum of 1 gram per day, given every 12 hours.
Ertapenem has that age restriction.
Yes. Metronidazole is 30-40 milligrams per kilogram per day, every 8 hours, and ceftriaxone is 50-75 milligrams per kilogram per day, every 12-24 hours. These doses are for intravenous administration and assume normal renal and hepatic function. Always verify current guidelines and patient-specific factors, of course.
Of course. Always double-check dosing for kids. Okay, given the evolving resistance patterns you've highlighted, antimicrobial susceptibility testing, AST, seems more crucial than ever. What are the contemporary resistance patterns we're seeing for Bacteroides fragilis across the board? What's the latest picture?
It's a critical area of concern, really. As mentioned, resistance to penicillin is almost universal, exceeding 90% due to that potent beta-lactamase production. Piperacillin tazobactam, thankfully, still shows excellent activity against most strains.
That's good news for Piptazo.
It is. However, we are seeing the emergence of carbapenem resistance, often mediated by the KFIA gene, with rates reported anywhere between 2% and perhaps up to 20% in different regions.
2 to 20% carbapenem resistance. That's definitely unsettling, as carbapenems are often our last resort.
It really is. And what about clindamycin and metronidazole, two other long-standing agents?
Yeah, what's their status?
Well, clindamycin resistance is now widespread. It can easily be over 20–30% in many regions, making it an unreliable choice for empirical therapy. We've really lost it for that purpose.
So clindamycin is really off the table empirically.
Pretty much. Metronidazole resistance, while still rare, typically 0.2 to 4%, is clinically significant when it does occur, and it's often associated with NIM genes. The key takeaway here is that the emergence of multi-drug-resistant strains, though uncommon, means we simply cannot rely on historical susceptibility patterns alone anymore.
So testing is essential.
Absolutely. For any Bacteroides fragilis isolate from a sterile site, routine antimicrobial susceptibility testing is now strongly recommended. It's moved from an option to a necessity.
A necessity. Got it. So for our medical microbiologist listeners, let's talk about the European Committee on Antimicrobial Susceptibility Testing, or EUCAS breakpoints. What do they need to know about interpreting these crucial results accurately?
Okay, EUCAS provides the standardized breakpoints that guide our interpretations. The most recent comprehensive table is version 14.0 from 2024. EUCAS specifically recommends performing AST for anaerobes on fastidious anaerobe agar, supplemented with 5% horse blood, intubated anaerobically for 42–48 hours.
Specific media and incubation.
Yes, and for quality control, Bacteroides fragilis ATCC 25285 is the standard strain we use.
Right, the QC strain. Can you give us the key EUCAS clinical MIC breakpoints for the Bacteroides fragilis group that are most relevant for our daily work?
Of course. For piperacillin tazobactam, a susceptible breakpoint is 16 milligrams per liter or less.
16 or less for Piptazo.
For meropenem, susceptible is 2 milligrams per liter or less, intermediate is between 2 and 8 milligrams per liter, and resistant is anything greater than 8 milligrams per liter.
Okay, meropenem has S, I, and R. 2 and 8 are the key numbers.
Correct. For clindamycin, the breakpoint is based on epidemiological cutoff values, with the susceptible at 4 milligrams per liter or less, and resistant being above 4 milligrams per liter. This is specifically intended to detect acquired resistance mechanisms.
EQOF for Clinda, looking for acquired resistance.
Exactly. For metronidazole, susceptible is 4 milligrams per liter or less. Wild-type organisms are inherently susceptible, and any detected resistance is considered clinically significant due to its rarity.
So any metro resistance is a red flag.
Definitely. And remember, ECA means susceptible with standard dosing, A means susceptible with increased exposure, and I means resistant. These are our fundamental guideposts for interpreting those MICs.
Excellent summary of the EUCAS breakpoints. Finally, let's turn our attention to infection prevention and control. Since Bacteroides fragilis infections are predominantly endogenous, arising from inside the patient, what's the core strategy for preventing them? It's fundamentally different from preventing, say, a hospital-acquired MRSA infection, isn't it?
That's precisely right. Prevention is fundamentally about preventing internal translocation rather than external transmission. It's about keeping it in the gut. So our strategies heavily focus on the perioperative period, aiming to mitigate the risk of surgical site infections, especially during procedures involving the gastrointestinal tract.
Makes sense. Focus on surgery. What are the key interventions that prove most effective in that perioperative window?
Well, they include appropriate antimicrobial prophylaxis, administered precisely before the surgical incision, ensuring it specifically covers obligate anaerobes when indicated. Timing and spectrum are key.
Prophylaxis. What else?
Beyond antibiotics, meticulous aseptic and surgical technique is paramount. We're talking about effective skin preparation, minimizing tissue trauma, and preventing contamination from bowel contents during the procedure. It's all about keeping Bacteroides fragilis where it belongs, inside the gut.
Careful surgery is infection prevention.
Absolutely. And what's our role as microbiologists in the lab, both in terms of safety and critically proper specimen handling?
I can't tell you how many times I've seen a perfectly good anaerobic sample ruined by a minute of air exposure. It really emphasizes that pre-analytical steps are half the battle in anaerobic microbiology.
You hit the nail on the head there. The quality of our anaerobic microbiology results hinges almost entirely on pre-analytical factors. Educating clinical staff on proper collection is crucial.
So what's the ideal specimen?
Ideal specimens for anaerobic culture are aspirates of fluid or pus or tissue biopsies collected via needle aspiration through disinfected skin. Avoid contamination.
And what about swabs?
Surface swabs are frankly unacceptable because they're invariably contaminated with commensal flora, and a good lab will often reject them for anaerobic culture. They just don't yield useful results.
Reject the swabs. Good policy. So proper collection and transport are absolutely vital for accurate results.
Absolutely. Specimens must be immediately placed into an oxygen-free transport system to ensure the viability of obligate anaerobes.
Immediately into anaerobic transport.
Yes. Even brief exposure to ambient air can be lethal to these sensitive organisms, leading to false negative results, which has significant clinical implications. And importantly, refrigeration should be avoided for most anaerobes, as it can actually inhibit their viability, counterintuitively.
No refrigeration either. That's a critical reminder for anyone handling these samples. Keep them anaerobic and at room temp. Wow, what a deep dive into Bacteroides fragilis. From its paradoxical life in our gut to its formidable role as a pathogen and the intricate details of its lab identification and treatment, we've really covered a vast amount of ground today.
We truly have. We've seen how this seemingly simple bacterium presents complex challenges, demanding a deep understanding of its biology, the diseases it causes, and the nuanced approaches to its management, especially with those ever-evolving resistance patterns.
Yeah, the resistance piece is huge.
It's a constant dance between treatment and surveillance,
Thinking about our medical microbiologist listeners, what stands out to you as the ultimate takeaway from all this information? What's the one thought you'd want them to ponder after this deep dive?
This really raises an important question, I think. How will the accelerating landscape of antimicrobial resistance, even in cornerstone drugs like metronidazole and carbapenems, shape our diagnostic and therapeutic strategies for Bacteroides fragilis infections in the next decade? The need for vigilant surveillance and rapid, accurate susceptibility testing will only grow. It's becoming even more central to our practice, wouldn't you say?
Absolutely. That need for good AST data is only increasing. A powerful thought to ponder as we continue to grapple with the global challenge of antimicrobial resistance. Thank you for joining us on this deep dive.
My pleasure. And to you, our listeners, we sincerely hope this deep dive into Bacteroides fragilis has equipped you with valuable insights. Remember, you can view the notebook document for a complete list of sources, and we always invite your feedback on this report in the comments section. Let us know what you think.
Yes, please do. Just a reminder that this deep dive is for informational purposes only. For medical advice or a diagnosis, always consult a professional. We look forward to our next deep dive with you. Stay curious.